Ahead and get started. My name is Susan Hepworth. I serve as Executive Director of the Children's Cardiomyopathy Foundation. I just want to welcome everybody to today's webinar, which is presented to us by Dr. von Alvensleben, a pediatric cardiologist at Children's Hospital, Colorado. And he's going to be presenting today on evaluating for ICD placement and the psychosocial considerations related to ICD placement. We have reserved time at the end for question and answer. So as questions come to your mind throughout today's presentation, go ahead and use the buttons at the bottom of your screen, either the Q&A or the chat box. And go ahead and type those into there and I will keep track of those. And then once the webinar concludes, we will tick through all of those questions, pardon me, with Dr. Alvensleben. So I will go ahead and turn it over to you to go ahead and get started.
All right. So I'll share my screen here. Get started here. Excellent. Well, welcome everybody. Good morning and good afternoon, depending on where you're tuning into. My name, as I said, Johannes von Alvensleben. I'm one of the pediatric cardiologists and electrophysiologists here at Children's Colorado. And today we're going to spend some time talking about ICD implant, why someone might need it, how we identify those people, how we go through the process, and then we're going to spend a little bit of time on living with an ICD. As I said, this is designed for patients and families. We're going to have some time at the end for questions, so please put those into the chat and we'll get to those and spend as much time as we need to. I've got no relevant financial disclosures. I will say that this is my email address, and I am very happy if you guys send me questions and we want to work through things. There are a lot of things that we're going to cover today, and if there are still questions afterwards that we don't even get to or that come up later on, please send them to me. So our objectives. So we're going to start by understanding a little bit, not only some of the underlying cardiac conditions, but we're going to talk about normal cardiac electrophysiology, how the electricity moves through the heart and how it can be abnormal, and then why an ICD can be helpful. We're going to talk about some of the conditions that are most commonly predispose patients to needing an ICD and focus on some of the cardiomyopathies. We'll talk about the different ICD systems and how they're used. And then, as I mentioned, we'll spend some time at the end with living with an ICD. What are some of the long-term management of patients with ICDs? So it's really important to identify some terms. And I think one of the challenges in cardiology, just like in any parts of medicine, is that we use many terms, frequently acronyms, and that aren't always identified. And then sometimes you read things in the news or on the internet, and terms might be used interchangeably, and they're not always interchangeable terms. So we'll run through a few of those things. So an implantable cardioverter defibrillator, that is an ICD. So these are devices that are designed to detect and then correct life-threatening cardiac arrhythmias. So these devices are implanted. Many of you have heard about things called AEDs, automated external defibrillators. These are the things that you see at schools and libraries and airports, that you take them out, and if somebody has an event, you put these patches on the outside of their body. Well, this is the same concept of an ICD, except these are implanted devices, and we'll talk about how that goes here in a little bit. The point of ICDs, and in many cases, ICDs allow patients to continue their normal lives with minimal interference. That is the point of these devices. They are implanted, they are with the patient, and they are there and vigilant, but they are not supposed to be interfering with daily life. And the process, and we're going to be focusing on that today, is you have to identify patients at risk, the diagnosis, and then implanting the ICD, the procedure. So that is something that is primarily what my job is as an electrophysiologist, is diagnosing and then procedural parts of the ICD. I'm going to use, let's see if we'll use a little pointer. Maybe this will be a little bit easier. Great. So important terms to identify and define: cardiac arrest versus a heart attack. These are terms that get thrown around a lot, and they are not the same. A cardiac arrest is this abrupt loss of heart function, and the most common reason for a cardiac arrest is secondary to an arrhythmia. Now, a heart attack is different. A heart attack, or an MI, is damage to the heart muscle secondary to this lack of blood flow or oxygen or something like that. That is something that we see older adults. There's a blockage in a coronary artery, and that portion of the heart does not get blood flow and it is damaged. Now, the most common cause of a cardiac arrest in adults is actually a heart attack. But in children, they're much more likely to have a cardiac arrest secondary to some underlying electrical problem or some underlying heart problem that predisposes them to abnormal electrical issues like cardiomyopathies, which we'll talk about. So these are two very different terms that are related but are not equal. And we will be talking about preventing or managing cardiac arrest, not heart attacks. So let's talk about the normal conduction system. So when we think about the heart, right, we've got 4 chambers. We've got 2 in the top. We've got 2 in the bottom. The top chambers are called the atria. The bottom chambers are the ventricles. And between the top and bottom chambers, we have these valves. And these valves are electrically insulated. So they don't let the electricity, which starts in the top chamber, make it to the bottom chamber. It all kind of gets funneled through the middle of the heart. So how does it do that? Well, the pacemaker of the heart is what's called the sinus node, the sinoatrial node, and it's usually up here in the top right chamber. And this is, as I said, the pacemaker. So it sends signals that faster signals when we're active, we're exercising, we're angry, we're sick, and it slows down when we're calm and we're sleeping. And these signals move through the top chambers of the heart. Okay, so they just kind of spread out through the top chambers of the heart. But these valves, as I mentioned, they kind of stop everything from moving forward. So then what happens is it moves through this kind of gatekeeper in the middle of the heart. This is the AV node, the atrioventricular node. This is, as I said, the gatekeeper. It allows electricity to move from the top chambers to the bottom chambers. So then signals move down, and then they move down through these kind of connections down to the bottom chambers, and it results in the top chambers beating and then the bottom chambers beating. And so that's the normal electrical system. But now where we are going to be focused on is abnormal heart rhythms that are in these bottom chambers in the ventricles. And it really doesn't matter whether they arise from the right side or the left side, but these are the arrhythmias that we are going to be dealing with today. These are different than the arrhythmias that can occur in the top chambers that many folks have, things like atrial fibrillation or atrial flutter. These are top chamber arrhythmias, and that's not what we're necessarily as concerned about. We are worried about bottom chamber arrhythmias. So what are those arrhythmias called? Those are called ventricular tachycardia and ventricular fibrillation. VT and VF, these are terms that get used a lot. And what that refers to is very fast and typically ineffective contraction or squeezing of the ventricular heart muscle. So the ventricles, these are the pumps of the heart. They are pumping blood to the rest of the body. And if they are not beating effectively, or they're beating so fast that there's not enough time to fill and squeeze out the blood that the body needs, then the body is ineffective and you have a cardiac arrest. And so these two types of arrhythmias are very similar, and they're just slightly different in the sense that ventricular tachycardia is very rapid but typically organized beats of just the bottom chambers. And ventricular fibrillation is this very, very extremely rapid quivering of the heart. And both of these essentially result in this ineffective, insufficient time for the heart to work the way it's supposed to. So what does this look like when we look at our EKGs? The EKGs, these are the tests that I'm sure many of you have had in the office. The stickers get placed on the chest. We look at the electrical activity of the heart in real time. And it's divided up, so each one of these is one heartbeat. We're going to focus down below. And just as I showed you in that other example, the electricity starts in the top chamber. So we have a little bump here. You can see this little bump. These are the top chambers beating. And then the electricity moves through the top chambers of the heart, and then it gets to the bottom chambers. And these big tall spikes, these are the bottom chambers of the heart beating. So in this example, this is a normal rhythm, top, bottom, and then this kind of bump here at the end, this is the heart electrically getting ready for the next beat. But what we care about and what we're focused on is top and bottom chambers beating. So what does it look like when it's not normal? So we had this example before. Here we have the top chamber beating, the bottom chamber beating, the top chamber beating, the bottom chamber beating, and that goes on. There's some abnormal beats, what we're going to ignore. But suddenly, this patient's heart rhythm has changed dramatically. It has gotten very, very fast. This is a very disorganized, chaotic heart rhythm where the bottom chambers are just going so fast that they can't effectively beat. And so this patient has gone into what's called torsades, or ventricular fibrillation, is what they state. And this is ineffective heart rhythm. So there's electrical activity. The heart is squeezing, but it's not squeezing in an effective way. The heart is functionally stopped. So what do we know that can cause these things? So there are many different kinds of reasons that patients might have these abnormal heart rhythms. And we're not going to focus on all of them. We're going to focus on the ones that we think about the most in children. And those are divided into these two main categories. They are the cardiomyopathies. So what we're going to be kind of relevant to what we're talking about today. Cardiomyopathies, as we know, are abnormalities in the heart muscle. So myopathies is abnormal muscle. So a cardiomyopathy is abnormal heart muscle. And these come in many different types. The most common, or one that is very common, is called hypertrophic cardiomyopathy. So hypertrophic cardiomyopathy is a thick heart, and we're going to show some examples of that. Arrhythmogenic right ventricular cardiomyopathy, or ARVC, as many of you have likely seen over the years, that we like to use these acronyms. So ARVC, instead of being a big thick ventricle, big thick heart, this is a stretched out, kind of very thin-walled heart, which we'll show. Ischemic or restrictive cardiomyopathies are different. These are much less common in children. Ischemic means that you had a time where there wasn't enough blood flow. So that's like a heart attack. Not enough blood flow. There has been damage to the heart because of that. Restrictive cardiomyopathies are myopathies where the heart muscle can't really relax. Now, these three kind of categories of cardiomyopathies are the most common cardiomyopathies that can cause cardiac arrest, and for reasons that we put in an ICD. However, many of you have probably heard of dilated cardiomyopathies. Dilated cardiomyopathies are different. This is where, again, much like ARVC, the heart usually becomes stretched out and the heart squeeze is quite poor. And while these are common, and while these patients are at risk, what we found over the years is that these patients are at much lower risk of sudden death due to cardiac arrest or these types of dangerous arrhythmias, and they're more prone to things like heart failure. And so they are very important to know about and manage. They are not at the same risk as some of the other cardiomyopathies for needing an ICD. And this has been something that we have discovered over a series of years, and has really actually changed over, I would say, the past decade, that we are realizing they don't require ICDs. Now, a different category, what we call these channelopathies, and these are abnormalities in kind of the primary electrical system. So these are things that you hear about, things like long QT syndrome or something else called CPVT. So these are different from cardiomyopathies that are abnormal heart muscle, and these are more primary abnormalities in the electrical system. So briefly, let's look at why these things are important. So here's this example of a patient with hypertrophic cardiomyopathy. We're looking from the top down. This is kind of the right side, right ventricle, but you can see this is the left ventricle, and this has been cut as part of a study. But so this muscle is very thick. This muscle is somewhere in the range of 10 to 15 times bigger than it needs to be. Here's another example. So here's the left side of the heart. This is very similar to what we were seeing way at the beginning when we looked at the electrical system. Here are the top chambers of the heart. Here is the right ventricle, and here is the left ventricle. And this is very massively thick heart. And the concern is not just that this is a thick heart. So this isn't just kind of a big, strong muscle. The problem is that the muscle itself becomes abnormal. As it gets big, as it gets thick, the muscle fiber, so here on the left-hand side, so panel A and C, these are normal heart fibers. These are oriented kind of in these kind of nice linear fashion. They're closely together. They have specialized areas that are kind of holding them together. And here down here, you can see this kind of nice linear aspect, long lines, whereas these abnormal heart, these are patients from hypertrophic cardiomyopathy. Not only is the muscle thick, but the muscle fibers are very abnormally formed, and this predisposes these patients to abnormal heart rhythms, and that is what's important. Now, on the other end of the spectrum is what's called ARVC. So that's what I was talking about, where the right ventricle, the right pumping chamber, gets very big. And what happens is, instead of the heart muscle becoming thick and disorganized, it becomes thin and disorganized, and portions of the muscle become very thin, and it's because they get replaced. Instead of good, strong heart muscle, it is this kind of fatty replacement that replaces it, and it predisposes patients to abnormal rhythm. And this is kind of a little bit of a blurry slide, but it's because it's a high power microscopy of some of that heart tissue, and all this white is fat, and it is replacing the good, healthy muscular tissue with all of this fat, and that results in these abnormal electrical activity that results in abnormal heart rhythms. So how do we decide when we start thinking about needing an ICD? What is the process going through? So we have a patient, let's say with a hypertrophic cardiomyopathy. And the question is, when does this patient need an ICD? So first is the two different reasons someone gets an ICD. And the terms that we use are what are called primary prevention and secondary prevention. Primary prevention means someone's getting an ICD before they've had any sort of life-threatening arrhythmia. So a primary prevention ICD is placed in a patient who is at risk for life-threatening arrhythmias. Versus secondary prevention, we put an ICD in someone who has already had that documented cardiac arrest or that documented dangerous life-threatening arrhythmia. So the goal is to identify patients ideally before they have an event. Primary prevention, but that is a challenge, right? So the best time to put in an ICD would be the day before that patient was going to have a cardiac arrest. That means that they didn't need to undergo an unnecessary procedure. They didn't need to have a device for an unnecessary length of time. If we could predict right when they needed it, and then we put the ICD in, that would be perfect. But that is a challenge. Now, many conditions, particularly hypertrophic cardiomyopathy, but many conditions have established risk stratification scores. We're not going to spend time on that today because they are incredibly complicated. And there is a lot of discussion because the factors that place, for example, a child with hypertrophic cardiomyopathy at risk for sudden death are very different, or can be different, than those risk factors that place an adult at risk. And so while we have risk stratification scores, there is still, as we'll talk about, a lot of discussion with patients and their families and the cardiomyopathy cardiologists about balancing the prevention of sudden cardiac arrest with the placement of unnecessary devices. Because we know we will never be right 100% of the time, but we want to be right as many times as we can. Now, the majority of ICDs in children are placed for secondary prevention. And the reason is that it is a challenge to predict which patients are at risk for sudden death. But even more than that is that for many of the conditions for which children get ICDs, that the cardiac arrest is the first sign of their disease, is that they were living completely normal lives and they present with a cardiac arrest, they're resuscitated, and then we place an ICD and have diagnosed them with this abnormal cardiac condition. So that is why the majority of ICDs in children are for secondary prevention. So let's talk about ICDs and what that means. So one thing that I think comes up, and I didn't really emphasize it here in the talk, is that for the vast majority of cases, vast majority with some exception, but the vast majority, every ICD is also a pacemaker, meaning that every ICD has pacemaker ability or the ability to do that. Now, so pacemakers and ICDs have two components. They have the leads. The leads are these long, flexible cables. And they, as we'll talk about in a little bit, are connected to the heart muscle from the inside. You can't really see here, but there's a corkscrew on the end of these, little corkscrew type things that we kind of screw. We physically screw that into the inside of the heart, and it attaches itself to the heart muscle, and it allows the device to sense electrical activity from the heart and then transmit signals to the heart. For a pacemaker, that would to help speed up the heart rate. For an ICD, as we'll talk about, that is to deliver an electrical charge to kind of reset the heart and break it out of this abnormal and life-threatening arrhythmia. So you have the leads, and then that is connected to the pacing generator or the pulse generator. This is about the size of an ICD. These are a little bit bigger than pacemakers. This is 99% battery and capacitor. So it's there to store a charge, hold a charge, and deliver a charge. There's also the computer algorithm that is there to take the signals that it's getting from the lead, analyze it, determine if it's abnormal, and then decide what to do about it. So the next part is, okay, we have a condition, we have determined that a patient needs an ICD. How do we get that ICD? How do we implant the ICD? How do we get to the heart? Well, the vast majority of devices, of ICDs, are what are called transvenous ICDs. What that means is that they utilize the veins to get access to the heart chambers. Transvenous. And these are the main veins that we use that drain the upper body and the chest. So what does that look like? So here we have an example. What's cut away, the heart sits right here. Sits right here. And these veins come from the arms and the upper body, the head, they connect together and they drain into the heart, which is right here. And so we utilize these veins right here in this area. We access these veins just beyond the collarbone, and we get access to these veins, and then we thread the leads that I showed you through the veins, and then we attach them into the heart. And so this is all done through a very small incision underneath the collarbone. And what it looks like when a patient has an ICD implant is like this. Here's the same example. So here's the patient's collarbone. Here's the patient's heart. And these veins traveled from the arms and the neck. And so an access was done right here. And the veins were placed, the leads were placed into the vein, threaded through the vein into the heart, and they were screwed into the heart muscle. And you can see here that these are very flexible. Here's a lot of slack. We place slack in the leads because children grow. So we need to have enough slack so the leads are secured here and they are secured inside of the heart, but generally they're kind of free floating inside of the heart. And so as the patient grows, this slack can be pulled out. Now the generator is over here. Now you can see that this generator is placed not where the lead is, but is over here in kind of the armpit, in the axilla. And that is what we do at our institution. And that is primarily, to be quite honest, a cosmetic thing. We place the device here because in small children, these generators might take up a little bit of space. And so cosmetically, we frequently place the generator here in the axilla and we tunnel the leads there. It also has some effectiveness in terms of its ability to deliver an effective shock, which we'll talk about. But this is an axillary generator. The majority of generators are placed right here. So the leads, little incision gets made and the pocket gets made here and the device is kind of tucked under the skin and over the muscle. And only the leads are going through the veins. So this is an example of a transvenous through the veins ICD, which is the most common type of ICD that is placed in children, but also in adults. Now you contrast this with a slightly more recent development, which is called the subcutaneous ICD, S ICD. And this, so if we look at this example here, is that here we have those same veins, right? When we talked about the old device, the other kind of device, it went through the veins, and then into the heart, which is kind of back here, if you look closely. The subcutaneous, it does not go inside the veins. It does not go inside the heart. What we do is we tunnel the lead under the skin, but over the ribs. And we secure it, and then we tunnel it along the breastbone. And so it sits here, and it accomplishes the same thing. It is on the outside of the ribs, so there's nothing that is inside the body. There's nothing that is inside of the heart. And this has been out for just over 10 years. So it received approval in the United States about 10 years ago. And this is far from experimental. So about 3,500 devices are implanted yearly. However, the vast majority of these devices are not implanted in children. They are implanted in adults. And the reason for that is that you have to screen in to receive this device. The way this lead detects electrical activity is different because it's not inside of the heart. It detects it much like those EKGs that you have when you go to clinic, where they put stickers on the outside of the chest. This lead does the same thing. And so patients have to screen in. And so, sorry, we'll use this. This is the chest x-ray. So again, the generator is in a very similar location as our devices. So it sits here. And this lead is tunneled on the outside of the body, on the outside of the rib cage under the skin. It's secured here just by the ribs, and then it goes up along the breastbone. And so here it's kind of sandwiches the heart in between it. And so you need to be able to screen in. Only certain patients are eligible for these devices. And the reason it does that is it has this little template to determine whether something is normal or abnormal. It says, does the heart signal fit within this template? And so this is a little bit of what kind of it looks like. It has this template. And if you look closely, there's that EKG symbol, that EKG, the kind of one beat that I showed you on the EKG before. Here's where the bottom chamber is beating. Here's where the heart is electrically resetting. And you can see that it's entirely within this little template. But when the patient was lying flat, part of it came outside the template. And when they were lying on their right side, a little part came outside the template. And so this patient is not eligible for that subcutaneous ICD. And so in studies, when we looked at this, so in the old way of doing it, almost 30% of patients failed the screening and were ineligible for an ICD. This changed slightly. They came out with a new screening tool that was more automated. And so the device itself looks at it and it tells us, okay, nope, it didn't work in this side, but it worked in these vectors. So this patient has 2 out of the 3 kind of criteria. So this patient would actually screen in. And what we saw, was that a higher percentage of patients do screen in. So just under 80% of patients do screen in for a subcutaneous ICD with this new device. And this is something that we've looked at our institution in young patients and children and young adults with congenital heart disease. And so subcutaneous ICDs can be very effective. They definitely have their place for a number of patients, but you have to screen in, so you have to be the right kind of patient. And one of the biggest issues is that many times patients with cardiomyopathies they failed the screening process because because their heart's electrical systems were so abnormal that they didn't qualify for a subcutaneous ICD. So what does that mean? What does it mean when I say that the ICD detects an abnormal electrical rhythm, and it does something about it? Well, this is what I mean. This is from the device, the ICD. So this is what it prints off. It is detected, the heart is in this very abnormal, very fast rhythm, and it delivers a shock through the lead. And this is essentially like a big reset. This is like pressing alternate control delete on your computer. It is a hard reset, and there's a big shock to the system. And then the heart breaks out of this abnormal arrhythmia, and then the electrical system is much more regular. Frequently, it's very slow, so the devices pace the heart for a period of time until the heart's electrical system picks up on its own. Here's another example of that very, very fast, abnormal appearing heart rhythm. A shock is delivered, and then the heart rhythm is much slower and much more regular. So what does it look like to be a patient with an ICD? So this is a video from a number of years ago. This is a professional Dutch soccer player who has a cardiomyopathy and who has an ICD and who continues to play professional soccer. And in this video, he is playing a game and he suffers a cardiac arrest. And so he collapses and his device detects it. It gets him out of the abnormal rhythm, and then he sits up. There's no CPR, there's nothing there, but I will say that you're going to see this. And so if it's something that feels a little bit disturbing to you, I would look away just for a little bit. It does show a good example of how this works. If we can get this to play here. Oops. See if we can try that one more time. Oh, I think it's because of the recording. Let's see if we can stop sharing for just a second and try that one more time. And then let's see if we use this example. And let's see. Well, it looks like because of the recording, it's saying it's an external thing. So in this example, so we'll skip this, but in this example, this is the entire process lasts about 10 seconds from the detection of the arrhythmia to getting him out, and then he sits up. He clearly doesn't continue with the game, but that's the way the ICDs are supposed to work. So with the, here, let's just get our pointer option again. So let's move on to kind of living with an ICD. Well, so the majority of children with ICDs can continue relatively normal activities. And what's important here is that having an ICD actually doesn't necessarily change what you can or cannot do. And this is important, is that it's not the ICD that might change what activities you are allowed for. It is more what is your underlying cardiac condition. So if you have a condition where you are restricted from athletic participation, that frequently the ICD does not change that. So having an ICD, as we'll talk about, really shouldn't influence that. It's primarily about your underlying cardiac condition. Now, living with an ICD, we've talked about implanting an ICD. So what does it mean later on? The battery typically lasts somewhere between 9 to 10 years. So, and the leads can last anywhere from 5 to actually probably 20 plus years. Replacing the generator is a day procedure. Patients come in, we open the incision where we place the device, we slide out the generator, we put the new device in, and we sew it up. They leave the same day. Replacing the leads is more of an involved procedure because the leads have kind of grown into the tissue. They've grown into the heart. So we have specialized tools that we move along the leads, and we actually kind of carefully cut them away, and then we remove them, and then we put the new system in. That carries slightly more risk. However, even though it's more involved, it still typically only requires an overnight stay. Now, replacing the leads again only need to be replaced if there is a problem with them. Many times they will last up to 15, 20 years. However, leads in children historically don't last as long as leads in adults. And that gets us to what are some of the concerns and complications of having an ICD? Well, procedural complications are rare, although device infections are possible. That's why when these are placed in an operating room setting, such that we want to keep everything very clean, because an infection means we have to take everything out. But the biggest thing that we think about as electrophysiologists are what are called inappropriate shocks. So we talked about appropriate shocks. The device appropriately senses something. It sees an abnormal rhythm, it delivers a shock. Usually patients are not even aware that they received a shock because they've fainted, they've lost consciousness, and they wake up and they're fine. You would have seen that on that video. But inappropriate shocks are when the device inappropriately thinks something abnormal is going on and it delivers a shock. And so that typically happens when somebody is awake, and that is painful and it's traumatic to somebody. So that is something that we work very, very, very hard to prevent. In adults, it's relatively uncommon, occurs in about 2 to 7% of adults. In children, it's much higher, and it can be up to 14 to 20% of patients because of a number of reasons. The first and foremost is that children's heart rates are just higher. More heartbeats and more active children put more stress on the device. And if you have lead damage, it's just like any wire. If the insulation begins to break, if the wiring begins to break, it can short circuit, it can send abnormal signals, and that can be an issue where the device sees something that's not really there or misinterprets it as an abnormal rhythm and delivers a shock. So the last things that we wanted to kind of spend some time is like the big ones. I think you guys, there was a talk a few months ago on sports and hypertrophic cardiomyopathy, it sounds like. So one of the things that people ask me is like, well, can my child with a pacemaker or an ICD, can they participate in sports? Like, what are their restrictions? And there it's something that I've been taught to say is, it depends, right? I think anybody asks you a question, anytime somebody asks you a question, the right answer frequently is it depends, because it does. So if we think about the device itself, so for example, if we think about patients with a pacemaker, they have a slow heart rate, so they have a device that's implanted. It's very similar to an ICD. The concept is the same, leads and a generator. And when we talk about those patients, they frequently have no restrictions to activity, although we strongly discourage them from doing full contact sports because we want to make sure we're trying to discourage activities that like actively might target and impact the device and the leads themselves. So things like boxing or mixed martial arts or football or hockey, where there's like repeated impacts to the device, that can lead to problems. But it also brings up the question about what is a contact sport. Those of us that have children who play soccer or baseball or basketball or have played those sports ourselves, we realize that many of those sports, there are impacts. And so there's a gradation. But when you take that same line of thinking to an ICD, the challenge is not just the device, it's the underlying condition, because we know that sports participation, getting your heart rate higher and getting higher adrenaline and catecholamines predisposes you to these abnormal heart rhythms. And so officially, patients who require an ICD are restricted to what we call class 1A sports. These are things like billiards or bowling or curling or golf. And those of you from the UK or India or that might be involved in cricket might bristle when cricket is listed as a 1A sport, but these are considered to be low impact, low stress activities. But as I said, typically the concern is the underlying heart rhythm condition and not the fact that you have an ICD. And so one of the things that we do here in Colorado that I think most people either do or should be doing is what's called shared decision making. Is we engage both the athlete, so the patient, and the family in a participation. And so many times it's myself, it's the primary cardiologist, it's the family, and we talk about this. And the cardiologist might say, okay, your risk is not 0, but it's low. And the family says, I understand the risk is not 0, but it's low. And there's this conversation with the school and those types of things, or the sports team. And many of our patients are still active in a variety of sports. They might be not active in certain sports, but it is a concept of trying to balance the risks of getting potentially an ICD discharge or damaging a device with the significant mental health consequences that we recognize of restrictions. And so one of the things that we definitely, at the very least, encourage is more habitual exercise, regular low impact exercise, rather than infrequent high intensity exercise. And one of the other things that we sometimes talk about is protective vests. For example, maybe patients that are playing a baseball, they might wear certain vests to protect their devices and things like that. Lots of questions about magnets and electromagnetic noise. So importantly, magnets temporarily disable ICD therapies when they are in close proximity. Walking by a magnet, is not going to do it. In the vast majority of cases, the magnets need to be within 6 inches. More powerful magnets can maybe be further away, but most magnets need to be pretty darn close. Now, why is this done? Well, this is a feature. Frequently, we use magnets to deliberately and intentionally disable therapies during things like surgery, because there they use electrocautery, and so that creates this electrical noise, and we don't want the device to sense that and deliver an inappropriate shock. But this is really different from pacemakers. Pacemakers, if you have a pure pacemaker, and a magnet will actually set it to a forced pacing mode. And so it's important, somebody who has an ICD but also requires that device for pacing, that a magnet acts differently. So if you have an ICD, it's a conversation to have with your electrophysiologist about what is the effect on you when a magnet comes close. So what does that mean? Well, there are so many magnets and opportunities for electrical noise in our environment. And over here on the right side, these are devices with very little risk. Microwaves, very little risk. Electric blankets and electric shavers and heating pads, these are primarily concerns for electrical noise, and they have very low risk in them. Most office and kind of light shop equipment, diagnostic radiation through chest X-rays and CTs have very little risk, if to no risk to devices. However, there are some things that have some risk and need to be understood. So the things that we think about, and a lot of people bring up, are things like airport metal detectors, cell phones, MP3 players. Airport metal detectors do have magnets, but walking through a magnet has essentially no risk. Having one of those wands kind of moved over the device will set off the metal detector, but just moving it over the device is not dangerous. You politely inform the security that please don't hold it over my device, but that is not something that needs to be reprogrammed or anything. Cell phones, particularly in the US, really don't have enough electromagnetic noise to affect the device. However, the more newer cell phones do have magnets that are part of their wireless charging, and so you don't want to be placing the device, these cell phones, right over the top of your ICD. Importantly, MRIs. So all MRIs are magnets, and all MRIs could potentially affect an ICD. However, the vast majority of ICDs are what are called MRI compatible, which means you can have an MRI, but many times we reprogram the ICD temporarily just to make sure nothing abnormal or inappropriate occurs, and then we reprogram it afterwards. So you can have an MRI, and remember that includes things like knee MRIs or a brain MRI or a neck MRI. It's not just heart MRIs. Things like TENS units, however, they should be used with caution, and they should not be used near where your device is actually. So to summarize what we've chatted about, ICDs are specifically implanted devices that detect and then intervene on life-threatening heart rhythms. The indication for implants are either primary or predicting before someone has an event, or secondary prevention, which is after somebody has had an event. Most ICDs are transvenous, they go through the veins, but some are subcutaneous, so they're outside of the heart, they're outside the ribs. Most patients with ICDs can really live relatively normal lives with sports participation determined by their underlying heart conditions. And while avoiding large magnets is important, most environmental magnets and electromagnetic noise will not significantly affect ICDs. And again, my email was at the beginning. Please feel free. We'll take some time. I think we have some time for questions, and we'll answer as many as we can. And I'll
Thank
stop
you so
sharing.
much, Dr. von Alvensleben. That was excellent presentation. And we have received several questions. So if anybody else has others, please go ahead and put those now into the chat box. So a few questions here. Is WPW considered a channelopathy?
Oh, great question. So WPW is called Wolff-Parkinson-White syndrome. It's not. So Wolff-Parkinson-White syndrome is secondary to an accessory pathway, so an extra electrical connection between the top and bottom chambers of the heart. So if you remember, we showed that example, the heart example, where you had the top chambers and the bottom chambers, and there were the valves between them that I said are electrically insulating. Don't let the electricity move there. Everything gets through the middle of the heart. Accessory pathways are little electrical connections that span those valves, and so they let electricity move through the top and bottom chambers, kind of a shortcut. And while they predispose patients and they place patients at risk for sudden death due to abnormal rhythms, they're not considered a channelopathy. And it's actually quite rare to get an ICD for that, because we can ablate those patients. We approach that and we ablate the accessory pathway, and that in the vast majority of cases is actually a cure.
Okay. So here's kind of a comment and a question. I am an adult male with an ICD implanted at Brigham and Women's Hospital. I've been living with it for 7 years. My son has HCM, so I'm attending this today to see if it should be a consideration for him.
Great question. Yes, so it's a great question, and it gets to that whole risk stratification model. And so it should definitely be a consideration. I think it is always a consideration for every patient who has, for example, like hypertrophic cardiomyopathy. What is this patient's risk of sudden cardiac arrest, and what is their risk of that? So needing an ICD, and what we do is it is based on things like how thick the heart is, particularly the septum. What maybe a Holter monitor looks like. Are they having abnormal heart rhythms on a baseline Holter monitor? Are they having unexplained fainting episodes? What does their echocardiogram look like? Is there obstruction to blood flow being pumped out from the body? And there's a number of these things. But as I said, one of the things, for example, that just came out was this very elegant risk prediction model that is designed more for children. And that showed us things that were different than the risk prediction model that was designed for adults. And so absolutely, it's a consideration, but I will say the vast majority of children or adults with hypertrophic cardiomyopathy do not require an ICD.
Okay, couple of questions here. Which one is more effective, ICD or S ICD?
Yeah, so they are both essentially equally effective at doing what they are designed to do. They are both equally effective if someone goes into an abnormal heart rhythm, to detect that abnormal heart rhythm and get you out of that abnormal heart rhythm. So they are both equally effective. There are differences. So a patient that has a pacing indication needs a primary pacemaker as well. A subcutaneous ICD is not designed for that at all. So that would be a hard stop. Patients that have top chamber arrhythmias, in addition to bottom chamber arrhythmias, the S ICD is more easily confused by that and might inappropriately shock a patient for a top chamber arrhythmia that didn't require a shock. So when we say, is it effective? They are both equally effective. However, one might be more indicated for a certain condition rather than another.
And then a follow-up to that is someone is asking about the life of the leads in S ICDs.
Yeah. A short answer to that is we don't know entirely well. Because they haven't been out as long, right? We do believe there is suggestive data that the leads are actually lasting longer than transvenously because there's less cardiac movement. There are, however, I will say, because the devices are newer, some of the older subcutaneous ICDs and their electrodes. There are some recalls, both on the generator and maybe some concerns with some of their leads. So overall, however, we think probably the leads will last longer, or there'll be less lead-related issues because there's not as much movement, but we just simply don't have enough data to fully say that yet.
Okay. Someone is asking, is there a minimum age for ICD placement?
Oh yeah. The short answer is no. What we did not talk about today is what's called epicardial devices. So a very tiny minority of ICDs are placed not just outside. So transvenous was inside the heart, subcutaneous was outside the rib cage. Epicardial means that the leads are actually placed on the outside of the heart itself. So that means the chest wall has to be opened, and then the heart is exposed, and the leads are sewn on the outside of the heart. And we do that in essentially babies that need an ICD. That is a very small group of patients. In general, patients, once you get to be 8, 9, 10 years of age, you can really probably get even a transvenous ICD, but that's lower than that. There's discussions about the risks and benefits of different kinds. For example, we placed a subcutaneous ICD in a 5-year-old patient, and in the traditional way, that worked very, very well. That patient could have also had a transvenous device, but that would have filled up a lot of the veins, and it potentially would have had more complications. So yes, there is an epicardial version, but so that can be placed in infants, but that's much less common. It's kind of just a different angle that you would take.
Okay. Someone asks about maybe some new technology advances. Are there new devices out there? How do you see things changing in the coming years?
Yeah. Well, I think that I will say this: the technology is likely going towards making the subcutaneous ICD and subcutaneous type devices better and more effective, not necessarily more effective, but more discriminatory, meaning in the way it works, and more universally able to be used. So I would say that if possible, the ability to avoid placing something inside of the heart does have many advantages. However, that, as I mentioned, some of the disadvantages of the current system means that it's not for everybody. And so some of the things that are on the horizon are things like leadless pacemakers. So leadless pacemakers are out. So these are, as the name implies, there is no lead. There's nothing long. There is a very small device that gets implanted inside the heart that is the lead and generator all in a very small package. And having that communicate with a subcutaneous device such that you don't have these long leads and those things. The other thing that is very exciting, which is a long ways away, is basically devices that recharge themselves, right? Devices that can be recharged externally, devices that use cardiac movement to create a little electrical activity to recharge themselves, much like electric cars recharge themselves with braking. As you brake, there's a change in the way these motors spin, and that recharge the battery. So, but the general trends would be more subcutaneous, leadless, and then kind of longer battery life, self-charging type things.
Okay. We've gotten a lot of really great questions, so we'll just keep ticking through them here. Can you talk a bit about guidance for LVNC and ICD placement?
Yes. So left ventricular noncompaction is what is. That's a great question, and there's even less guidance than even for hypertrophic cardiomyopathy. So hypertrophic cardiomyopathy, very, very common. Lots of patients really trying to develop these. LVNC, so non-compaction, that is a challenge because even the diagnosis is challenging. There are patients where they appear to have non-compaction, but it might be just the way their hearts look, and there's actually nothing wrong with their hearts. It is a lot of times what we are doing is saying, okay, how is the heart functioning? And what signs of kind of heart muscle irritability are there, like Holter monitors, How do we see abnormal heart rhythms spontaneously occurring when we do exercise? When they exercise, are we seeing that higher heart rates are irritating the heart? So we see these non-sustained abnormal arrhythmias. So it's things like that. But I think that, to your point, primary prevention, right, trying to predict before somebody has an event in LVNC is a challenge, because it is this process that you might be diagnosed with it, and it could be decades before you are at risk of any sort of abnormal heart rhythms, or I would say significant abnormal heart rhythms. You could be having irritability, but it doesn't mean that you're actually going to have a cardiac arrest. Okay. So unfortunately, it's a very individualized approach to patients as well as center to center.
Okay. Someone is wondering about the frequency of false shocks with ICDs.
Yes, the inappropriate shocks. Yeah. So yes, the frequency varies. And I will say that despite our best efforts, children and those with congenital heart disease, but definitely children who get ICDs, have a significantly higher risk of inappropriate shocks than adults. That is across the board. And that it is, and it has been historically the same, that when the studies have been done 20 years ago to look at this, we saw that rates were high, and they continue to be high. Now they are coming down. So the risk of inappropriate shocks are lower now than they were before, but they continue to be higher than in adults. And so we will quote anywhere from about 10 to 20% risk of an inappropriate shock, depending on why folks have an ICD. I will say that at most large centers, the rate of inappropriate shocks is lower than that, is on the lower end, more closer to probably 10%. But it is the reason why we are careful, and I think ICDs are more frequently placed in adult patients for more borderline indications, because that their risk of an inappropriate shock is so low. Is that if you see an adult patient, you might say, okay, I think that you are at risk, and because the risk of placing the ICD is so low, let's be more safe than sorry. And if a patient might be 70 years old, that also might mean that the duration that they'll have the device will be much shorter than in a child who might be 15. And we say, wow, you have 60, 70 years of having a device ahead of you, and needing generator changes and lead changes, and having that risk of inappropriate shock. So that's one of the reasons why far fewer ICDs are placed in children, and our threshold for placing an ICD is higher, not because it's just inherently dangerous or more difficult, but it's just a different risk calculus, and the risk is occurring for a long period of time.
Okay. And a couple of more questions, and then we'll have to end here. You mentioned that the leads in the veins have slack for when the child grows. Are the leads in the S ICD the same? I didn't see that much slack in the pictures.
Yeah, no, great question. Yes and no. We do try to put some slack. Sometimes the slack is actually, so a lot of times there's more what we call vertical growth. There's obviously growth out, but even if you look at a fully grown adult and their chest wall it has gotten bigger, but then the distance that kind of occurs is less. And so we do want to place slack, but the differences are not quite so great. And also, we're not necessarily talking about feet of growth in the chest wall. So while someone might go from 4 feet tall to 6 feet tall, you don't need 2 feet of slack. You really only need a few inches of slack to accommodate that amount of growth. So it's a great question. We do put a little bit of slack, but the slack is less here, and it's more in the distance from the middle of the chest to the S ICD, and we incorporate it there.
Okay. Just 2 more questions. And then we did have somebody ask, can I watch this recorded webinar again? Yes, it will be up on CCF's website, and it will be in the next newsletter as well. And we'll put that on social media. Do we know how much stretching is tolerable specifically for SICD that's just below the skin? Things like yoga,
Oh, yeah.
ballet, Pilates, things like that.
In general, whether it's transvenous or it's subcutaneous ICDs, those types of activities in general are very well tolerated. They're very durable. I mean, there are examples, for example, in terms of when we talk about actually the lead strength, that type of thing, they can hold up pianos, right? So huge amounts of weight. They're very strong. And then one of the things is, well, if you're stretching and right, you have something under the skin and you're stretching tight, patients, you can, for example, if you're very lean, you might be able to feel that. You might not be able to see it, but you could feel it. That's not painful to kind of press on. So even if skin was a little bit tighter from a stretching, you usually don't have that issue. So it's a great question. We don't think about it as much. One of the things with transvenous leads, when you place that lead, you want to give it some time to grow in. So usually for about 6 weeks, we say no lifting the arm, right, and moving. With a subcutaneous ICD, actually, there are none of those arm restrictions, but we want everything to heal before you get very active again.
Okay. And one final question, and this is a little bit clinical. What are the indications for unicameral and bicameral ICD in a child with ventricular tachycardia, secondary to ventricular dysfunction and myocardial fibrosis on resonance?
Yes. So I think what the question is asking is probably single coil. So so there might be two things asking. One might be saying single chamber versus dual chamber. So that means having a lead in the top chamber and the bottom chamber. So that I think is actually what the question is, bicaval versus single cable. I think is meaning a dual chamber versus single chamber. Or the question might be asking, I doubt this, is what's called single coil versus dual coil. So ICDs at the very end have a coil. That is where kind of the shock is delivered, right? That's where the electrical, and some devices will have one coil and then another coil kind of behind it. Most devices only have one coil, but I believe the question is single chamber versus dual chamber. It's a great question. We say, so if somebody needs pacing, so if somebody has a very slow heart rate or is going to be given medications that are really going to drive their heart rate really low and they're going to need pacing, we frequently will put in a dual chamber device. There will be one lead that sits in the top chamber, the atrium. And if you remember, that's where the electricity starts. So the normal heart, normal pacemaker, the sinus node beats, the device senses that. And then if the bottom chamber is too slow, it will then deliver a little pulse, not a shock, but a paced beat. So now the top chamber can either pace or sense, and the bottom chamber can either pace or sense. So somebody who is very, very slow heart rate will frequently get a dual chamber device. Or if somebody has a lot of top chamber arrhythmias, you might put a dual chamber device, so then the top chamber lead can detect those arrhythmias and tell the bottom, tell the device, no, don't shock. This is a top chamber device. Your question was fibrosis, I think on an MRI, so resonance imaging, I think so. Ventricular tachycardia in a patient with fibrosis on an MRI. It is, most of those patients might be someone, for example, that has hypertrophic cardiomyopathy, thick heart. They had an MRI and they saw scars on the heart. That is typically one of, but not usually the only reason someone would get an ICD. So a patient with hypertrophic cardiomyopathy who has scars on their heart because of how thick and abnormal things have become, and their heart is thick, and maybe they have this risk factor and this, the scar is used as one of the risk factors, but is rarely the only risk factor to get an ICD. But if you have ventricular tachycardia and scars, many times patients would get an ICD. If your heart rate is slow, you would many times get a dual chamber device. If you just need basically a backup, something that's watching, you would get a single chamber ICD. The picture that I showed, the transvenous ICD, that was a dual chamber ICD, leads in the top and the bottom chambers.
Okay. Dr. von Alvensleben, we've received tons of great feedback. Everybody thoroughly enjoyed your presentation. So thank you so much for lending your expertise and your time with us today.
My pleasure. Thank you so much for the invitation.
Thank you, everybody. Have a great day.